Chairman and ladies and gentlemen, it is my real pleasure to join this wonderful meeting. I'm going to cover the title, Tumor Ablation, Is RFA the Future? During the next 20 minutes, I'm going to cover these areas. First, I'm going to explain briefly the development process of ES-guided RFA probe. RFA is local ablation modality by delivering energy to the target area. It is composed of RF electrode down left side PIA and RF generator down right side PIA. RF generator supplies RF power and produces voltage difference between active electrode and the reference electrode. RF electrical field oscillate with RF frequency and causes oscillatory movement of ions in the tissue. This movement will create frictional heat, and tissue heating is the main mechanism of RF ablation. Percutaneous RFA has been used in clinical practice for a long period of time and mainly done by interventional radiologists. On the other hand, ES-guided RFA is relatively new field. The first ES-guided RFA was tried in animal by Harvard group. They developed this needle-type electrode and they used it in porcine pancreas under ES guidance. The result was reported in GIE 1999, more than 20 years ago. Upper panel is CT image and the lower panel is autopsy findings. In acute phase, CT shows necrotic low attenuation ablation zone and the autopsy shows a large area of burn injury. 2 weeks later, CT follow-up shows the shrinkage of ablation zone with enhancing and autopsy also shows fibrotic shrinkage. This group showed the technical feasibility of ES-guided RFA in porcine model. Thereafter, several groups reported the possibility of ES-guided RFA using animal models, but none of these studies translated into human clinical trial. Our group was interested in ES-guided RFA and started collaboration research with the STAMED company, which is one of Korean company producing RFA devices. We designed a prototype ES-guided RFA electrode and started ex vivo study first. We tested different settings of RFA, 30 watts, 50 watts, 80 watts, and 6-minute ablation and 12-minute ablation. Then we measured the shape and the diameter of ablation and the volume of ablation. After all these experiments, we selected 1 cm electrode for in vivo animal study and started in vivo ES-guided RFA using porcine model. Under ES guidance, we inserted 18-gauge needle into the pig pancreas. Here we can see the distal tip and the proximal marker of RFA electrodes. By turning on the power, we can see clearly echogenic cloud formation, and this area is ablated area by RFA. Based on our previous experiments, our protocol is using 1 cm electrode, 50 watts, and 5-minute cauterization. When we performed autopsy 1 week after RFA, we were able to see the round ablated area in the pancreas. The size was about 2 cm by 2 cm. Histology showed well encapsulated necrotic zone and normal pancreatic tissue, and these 2 areas are clearly demarcated by fibrous wall. This result was reported in GIE 2012. Let me move on. Initial human clinical trials. After completion of ex vivo and in vivo animal study, we published that data. Then we decided to conduct human clinical trial. And the first target was pancreatic cancer, but it was quite difficult to start human trial because of IRB issues. When we first submitted the protocol, IRB asked for revision because there was no data about the safety and the efficacy of US-guided RFA. After several revisions and resubmission, finally, we got approval from IRB, and these are IRB-approved inclusion criteria. It should be histologically confirmed pancreatic cancer, and it should be advanced and unresectable case. Even though it is unresectable, chemotherapy should be done first. If chemotherapy fails, then we can enroll this patient in our RFA trial. So it is only at the last moment of pancreatic cancer. This is one of the included patients, 66-year-old male patient with pancreas head cancer here. Initially, neoadjuvant chemotherapy and SBRT was done after metal stent insertion. Neoadjuvant therapy follow-up CT scan shows marked size shrinkage, so we sent this patient to surgery. However, when the surgeon opened the abdomen, there was undetected omental seeding, so the surgeon did just ONC and then sent this patient to oncology department. The oncologist tried second-line chemotherapy using FOLFOX regimen, but the tumor showed progression even after second-line chemotherapy. So this case was enrolled in our study. This is CT scan at the time of enrollment in our RFA study. This is video at the time of RFA. Initially, we tried conventional linear EUS, but it was difficult to insert RFA probe due to angulation of the scope. So we changed our scope to forward-viewing EUS. We can see large hypoechoic tumor, and the RFA electrode is inserted in the deepest part of cancer. Then started ablation from deeper parts. Then we rejected the electrode to the superficial parts to create another area of ablation. After this, we changed the needle direction into this area and create another line of ablation. These are just one plane ablation. So after this plane, we removed the electrode and tried to find another plane and repeated the procedure. We used 50 watt power, 10-second ablation with continuous mode. A total of 8 different spots were ablated. This is CT scan 1 day after RFA. We can see necrotic ablation inside the tumor. This is 1 month after. The tumor shows shrinkage and cavity formation inside. When we compare 1 day after and 2 months after, we can see clearly the marked volume reduction of the tumor. During this study, we enrolled 6 patients, and this table summarized the patient's characteristics and lesions. US-guided RFA was possible in all 6 patients, and there was no significant complication except mild abdominal pain after RFA. We reported this result in GIE 2016, and our conclusion was US-guided RFA is technically feasible and a safe option for unresectable pancreatic cancer. However, this study is just initial pilot study to see the technical feasibility, and not the type of study to see the therapeutic efficacy or long-term survival. Then we move on to the next topic, US-guided RFA for benign tumors. These are current indications of US-guided RFA. Neuroendocrine tumor, solid pseudopapular neoplasm, pancreatic cancer, and adrenal tumor. Although there can be some controversies, I think the indication can be widened more if we accumulate more data and the experience. This 43-year-old male patient suffering from MEN1. This patient received multiple operations. Distal pancreatectomy due to tail tumor and adrenalectomy due to Cushing syndrome, and the ependymoma, myelin operation, parasithoid operation. Now, on this MR image, we can see the newly developed neuroendocrine tumor at the resection margin of the pancreas. The patient refused any more surgery, so we decided to do US-guided RFA. This is US view at the time of RFA. 19-gauge RFA electrode was inserted into the deeper part of the tumor on the right side of the tumor on US screen. We started ablation by applying 50 watts power and 1-point ablation. Then after one side ablation, we return the electrode to the superficial part. Another ablation. And after this one line of ablation, change the needle direction and created another ablation. But this is just one plane ablation. After one plane ablation, we removed the needle and tried to find out another plane and repeated the procedure. Left side is MRI image before RFA, and the right side is 1 month after RFA. This CT follow-up shows necrotic area inside the tumor. This is 9 months after US-guided RFA. We can see marked decrease of the tumor. On the right side, we cannot identify the tumor anymore. This table shows the summary of our experience. We enrolled 1 insulinoma and 2 SPN and 7 neuroendocrine tumor in our US-guided RFA trial. Among them, 70% of the patients showed a complete response, morphologically complete response after US-guided RFA. Complication, there can be some abdominal pain or self-limited pancreatitis, but there was no life-threatening complication. Let me move on to the last part, future perspective. During this trial, we recognized that there are several technical issues to be solved for widespread use of US-guided RFA. The first was device modification. There are 2 types of RFA probe, needle type and fiber type. Left side is 19-gauge needle type electrode from StarMed company, and it is relatively stiff and cannot be used in highly angulated location. Right side is 1 French fiber type electrode from Habib company. It is quite flexible and can reach any area once FNA needle is inserted. But this probe can easily bend after exposure from the needle tip. Regarding ablation volume, needle type can create 3-dimensional ellipsoid ablation, more than 1 cm in length and 8 mm in diameter. However, fiber type electrode can create only linear thread-like ablation and cannot ablate large volume of tumor. So, if we can have needle type electrode with high flexibility, it would be more preferable. Second issue is possible complications. When we look at intraoperative RFA data, severe necrotizing pancreatitis and life-threatening bleeding complications are reported. This is the result of aggressive RFA in the surgical field. This is one of Chinese group report showing 25% mortality rates after intraoperative RFA. The main cause of death was massive bleeding after ablation of tumor located closely to the main portal vein. These are potential complications after US-guided RFA of pancreatic cancer. Pancreatitis, MPD stricture, perforation, or bleeding. When we are trying RFA of pancreatic tumor, we should remember that pancreas is very close to many vital organs. We applied US-guided RFA for unresectable pancreatic cancer and confirmed that we cannot completely eradicate the tumor cell by RFA alone. It is because unresectable pancreatic cancer already infiltrated into critical structures such as celiac artery, SMA, or pancreatic duodenal groove, or portal vein. So it would be better to combine RFA with conventional chemotherapy. So we adopted this concept in our human clinical trial. And this is one of included pancreatic cancer patients. Combined RFA and chemotherapy. Here we can see large tumor mass initially in the head of the pancreas. We did RFA and combined chemotherapy several sessions. Now we can clearly see the size decrease of original tumor. This is another case. We can observe low attenuation necrosis caused by RFA and chemotherapy. This study is still going on. When we did the interim analysis, 22 patients were enrolled. The mean size of the tumor was 4.2 cm. Chemotherapy plus RFA was done in 14 cases, and chemotherapy, SBRT, and RFA were combined in 8 patients. When we look at the survival of included patients, 1-year survival rate was 71.4%. 2-year survival rate was 56.3%. And mean survival was 750 days, more than 2 years, in unresectable locally advanced pancreatic cancer. We think this is optimistic results, and this trial is still going on. When we compare the locally advanced pancreatic cancer with metastatic pancreatic cancer, there was significant 1-year and 2-year survival difference. We are still enrolling the patient and following the patient. Hopefully, we can get good long-term outcome. Ladies and gentlemen, I'd like to conclude my talk with this final slide. US-guided RFA for tumor ablation is technically feasible and relatively safe. The indications are extending from pancreatic tumor to adrenal, hepatic, mediastinal, and peritoneal tumors. I think this is promising tool for non-surgical futuristic management of various tumors. Thank you very much for your kind attention.
Thank you, Vipul, and thank you, Dongwang, for a wonderful talk. As usual, you were precise and to the point. It's still early days for pancreatic cancer treatment by US RFA. And as you rightly said, yes, we need to include RFA in the algorithm of treatment at some point of time. We are nearing that where RFA can be added to chemotherapy. As your study shows, your experience shows that the survival benefit of more than 2 years is pretty good when you combine RFA followed with chemotherapy and radiotherapy. You very nicely also showed the evolution of RFA from animal experiments to the human experiments. And there's a further experience being added on in this front, apart from pancreatic adenocarcinoma and pancreatic neuroendocrine tumors and pancreatic cystic lesions also where RFA has been used. And this is quite an exciting area where personally I feel that RFA is quite safe, provided we do not go through the vessel or vital structures of pancreatic duct and the bile duct. And the symptomatic neuroendocrine tumors, they respond quite well. The insulinomas respond very, very quickly. Within the first 24 hours, the symptoms improve and the insulin levels and C-peptides come back to normal. And they have a sustained effect for more than 4 years, as we have gathered in our experience now, that one session of RFA does very well. And hence expansion to the non-functional neuroendocrine tumors, which are many, many available now. Because of the transabdominal imaging done so frequently of the good quality ones, the MRs and the CTs, which are incidentally picking up. And FNA of these patients, they show whatever grade of the lesions, but they still have a chance of spread. And that's where I think US is going to make a major difference in the overall management. Currently, which is surgery. And as we all know that surgery in a pancreatic neuroendocrine resection surgery. It can be distal pancreatectomy or Whipple's, depending on where it's located. And the current expected or accepted risk is 50%. Adverse event is accepted by the surgical field. And RFA has, I think, less than 10%, as John Wang series shows, and some other series also have shown that less than 10% of the patients have adverse events. So I think that's where another area where EU is going to make a huge impact in times to follow of RFA guided ablation of these tumors by EU is. Of course, side drawbacks are there, that is risk of pancreatitis, but if you take due precautions of using prophylaxis, using suppository with indomethacin, just like we do for ERCP, as has been shown by the French colleagues. And we often use a pancreatic stent placed 1 or 2 days before, if the needle happens to cross the duct while hitting the tumor. And all these work well to prevent pancreatitis, which can be disastrous. Some of the tumors do bleed, but that's a neuroendocrine tumor's characteristic, that they are very vascular. In all, I think, as Vinay, you rightly said, and Jongwen, as you rightly impressed upon everybody, that RFA is going to stay. It is going to be more useful probably for neuroendocrine tumors and as an add-on therapy in pancreatic cancer.